Yes, thank you very much, Lina, and many thanks to EMAS for inviting me to speak about a very interesting topic in our everyday clinical practice management of osteoporosis treatment options. We know that osteoporosis definition is a systemic bone diseases with the low bone mass and bone mineral density, with decreased bone strength and subsequent increased risk for fracture. And pathogenesis is based on an imbalance between osteoclast-mediated bone resorption and osteoblast-mediated bone formation, with a subsequent bone resorption increased with bone loss as osteopenia, osteoporosis, or severe osteoporosis, that is osteoporosis with complication of a fracture. And we know that usually the adherence to therapies for osteoporosis is generally low, with an important negative impact in terms of clinical efficacy as for our treatments for reducing the risk for fracture from osteoporosis condition. I'll speak about mostly on treatment today, and I start from estrogestins in premenopause. We know that estrogestin can maintain bone mass in women aged 41, 49 years with sufficient potency, and more interestingly, can decrease the risk of hip fracture if used after the age of 40 years. And about the different kind of therapies available for prevention and treatment of postmenopausal osteoporosis, we can divide the treatment into two large groups: anti-resorptive, such as HRT, estrogen alone, tibolone, raloxifene, basidoxifene; tissue-selective estrogen complex, that is the combination of basidoxifene conjugated estrogen, bisphosphonates, denosumab. We have also anabolic agents as teriparatide, and anabolic and anti-resorptive romosozumab, and another dual agent bone-forming drug as strontium ranelate. As for hormone replacement therapy, when I start hormone replacement therapy, I can have some differentiated effect on osteocyte, osteoblast, and osteoclast by the estrogen modulation, with a net final effect of increasing bone mass, bone strength, and reducing the risk for fracture. And this is the result of ORAG meta-analysis on 57 randomized control trials that have showed an important increase in terms of BMD at lumbar spine, femoral neck, and forearm. And another characteristic of estrogen therapy is that also with low-dose estrogen therapy, we can protect significantly bone mass in comparison to placebo. For example, in this slide is reported the effect of 0.3 milligram of conjugated estrogen that can protect significantly lumbar spine and total hip. And the Women's Health Initiative showed us an important reduction in terms of risk of hip fracture and vertebral fracture. So estrogen replacement therapy, hormonal replacement therapy is very important in preventing the risk for osteoporotic fracture. And tibolone is another type of hormone replacement therapy. As we know very well, tibolone after oral ingestion is metabolized in three metabolites. Two of them have important histogenic activity. So the study on tibolone, the so-called selective tissue estrogenic activity regulator, showed an important protection at lumbar spine and femoral neck, also in a long period of observation until 10 years, without loss of activity during this long period of observation. At the dose of 1.25, tibolone is able to reduce the risk of new vertebral fracture and non-vertebral fracture in an older population with a mean age 66 years in the lift study long-term intervention on fractures with T-bolon. Another class of drugs used in osteoporosis prevention and treatment are SERM, selective estrogen receptor modulators. They are compounds with the estrogen agonist or antagonistic effect based on different tissue. The two most studied and used in the field of osteoporosis are raloxifene and basidoxifene. Raloxifene is able to protect lumbar spine BMD and femoral neck BMD in comparison with placebo, and to reduce significantly the risk of vertebral fracture, both in a population with prevalent fracture and without prevalent fracture. Unfortunately, raloxifene is not able to decrease the risk in non-vertebral fracture risk. But interestingly, raloxifene can reduce the risk of breast cancer when used in a postmenopausal woman. Basidoxifene is the evolution of raloxifene, and in the osteoporosis prevention study showed the ability to protect lumbar spine BMD and total hip BMD similarly to raloxifene, but significantly in a way that's significantly different in comparison with placebo. And basidoxifene can reduce new vertebral fracture in general population, but also in subject with previous fracture in a significant way. And in an high-risk fracture population, basidoxifene can reduce also non-vertebral fracture risk differently from raloxifene. TSEC, tissue selective estrogen complex, is the combination of basidoxifene, a SERM, at the dose of 20 milligrams with conjugated estrogen at the dose of 0.45 milligrams, used for menopausal complaint, but also for osteoporosis prevention in postmenopausal women. In this study by Lindsay, we can see the very significant effect of protection on BMD, very different in comparison to placebo, and both at lumbar spine level and hip level. Very interesting, the use of TSEC for the virtual absence of the effect on breast tissue. Bisphosphonates are the most important and most used drug in the world in the management of osteoporosis. They are pyrophosphate analogs in which oxygen atom is replaced by C atom. In the molecular structure, we have two substituents, R1 related to the affinity for hydroxyapatite and R2 related to anti-resorptive potency. This is the well-known so-called bisphosphonates tree that contains all bisphosphonates now available for treatment of osteoporosis. In general, the mechanism of action of bisphosphonate is inhibition of hydroxyapatite crystals breakdown, suppression of bone resorption with the significant decrease of osteoclast inhibition, and decrease of both osteoblast and osteocyte apoptosis. So, reducing bone turnover, we have an increase in bone mineral density, an improvement in microarchitecture and mineralization with a subsequent increase in bone strength, and a significant reduction in fracture risk. Alendronate is one of the most important and most well-known among bisphosphonates, and in the FIT trials has demonstrated a significant reduction of risk in terms of reducing the risk of new vertebral fracture, multiple new vertebral fracture, clinical symptomatic vertebral fracture, hip fracture, wrist fracture. Very potent activity in terms of anti-fracture and anti-refracture activity. Also, risedronate has very good results in terms of reduction of vertebral fracture risk and non-vertebral fracture risk, similar to alendronate. Zoledronate is the most potent pharmacological speaking, in terms of reduction of morphometric vertebral fracture, hip fracture, non-vertebral fracture, any clinical fracture, a clinical vertebral fracture. An overall global, very potent effect in terms of reduction of fracture risk. Ibandronate can decrease vertebral fracture. Usually it is not able to reduce non-vertebral fracture, but also only in a post-hoc analysis on high-risk patients, it has a significant reduction of non-vertebral fracture. As for bisphosphonate safety, an argument well known about ONJ and atypical femoral fracture, we know that the incidence of this side effect, important side effect, is very low, and is very low considering mostly the benefit that we can have with the therapy with the bisphosphonate in terms of reduction of fracture in our patients. But which is the optimal duration of therapy with bisphosphonates? After 5 years with bisphosphonate, we can re-evaluate our patients, and if the patient is at low risk in terms of normal BMD range and no fracture during therapy, we can propose a so-called drug holiday, while if the patient is in a high-risk condition with osteoporotic BMD range and or history of fracture, we can continue treatment with bisphosphonate for 1 to 5 years again, or switch the treatment to another kind of drugs, or for example, a more potent anti-resorptive as denosumab. And these are, in one slide, all the dosages and administration for bisphosphonate in osteoporosis management. You can see alendronate, risedronate, zoledronate, ibandronate. And let's go to speak about denosumab, a rank ligand inhibitor. Denosumab is a monoclonal humanized antibody against rank ligand. And blocking the rank ligand, we can have an inhibition of formation, function, and survival of osteoclasts with subsequent inhibition of bone resorption and relative increase in bone formation with an important gain in terms of BMD. When I propose an injection of denosumab, we have an important reduction of serum CTX, a marker of bone resorption, an important increase of lumbar spine BMD. After 6 months from the previous injection, we have to make another injection to maintain the benefit in terms of lumbar spine BMD and decrease the level of serum CTX. So the effect of denosumab in terms of BMD and bone turnover inhibition are totally reversible. And we can see the important gains in terms of BMD at lumbar spine and total hip, with very important gains. And another very interesting point in the pharmacology of denosumab is that denosumab is able to protect trabecular and cortical bone with a global overall protection at all sides of the skeleton. This is the summary of the effect in terms of reduction of fracture at vertebral, non-vertebral, at hip level, very important reduction of denosumab in the FREEDOM study, that is the most important study about the effect of denosumab on osteoporosis. And denosumab has a very prolonged effect, as demonstrated in the extension study of the Freedom study. And denosumab treatment for up to years has showed persistent reduction in bone turnover, continued increases in BMD without therapeutic plateau, and low fracture incidence. But what about denosumab discontinuation or delay? A drug holiday or treatment interruption is not recommended with denosumab, but denosumab dosing should be not delayed or stopped without a subsequent anti-resorptive therapy to prevent a rebound in bone turnover and the decrease to the risk of rapid BMD loss and increased risk for vertebral fracture. So it's advisable to use bisphosphonate, for example, after we stop denosumab to protect our patient. Strong superannullate has demonstrated a reduction in vertebral fracture and non-hip fracture risk in a high fracture risk subgroup, but we know that now the use of strong superannullate is limited by a series of cardiovascular, hypersensitivity, allergic, possible reaction in clinical practice. Teriparatide. Teriparatide is the fraction 134 of recombinant parathyroid hormone. It stimulates osteoblast activity, and so it is an anabolic agent. Teriparatide has shown to be able to reduce significantly the risk of new vertebral fracture, very important reduction of moderate and severe new vertebral fracture, multiple vertebral fracture, and teriparatide can decrease also the risk of non-vertebral fragility fracture. According to its mechanism of action, so the stimulation of the osteoblast, we have very important gains in terms of BMD at the lumbar spine, femoral neck, total hip level with teriparatide. This is the summary of the effect in decreasing fracture risk at vertebral and non-vertebral fracture on the level, about the anti-fracture efficacy of teriparatide. Romosozumab is a relatively new bone-forming monoclonal antibody that inhibits sclerostin with a dual effect of increasing bone formation and decreasing bone resorption. Very interesting from a pharmacological point of view. It's administered once monthly, 2010 milligrams subcutaneously, for 1 year, producing a marked increase in spine and BMD. FRAME study, fracture study in postmenopausal women with osteoporosis, FRAME, is a very important study in the development and clinical use of romosozumab. It enrolled 7,000 postmenopausal women, age range 55 to 90 years, with a T-score of -2.5 to -3.5 at total hip of femoral neck. Randomization 1:1 to receive romosozumab subcutaneously or placebo monthly for 12 months. Thereafter, each group was switched to denosumab for other 12 months, every 6 months. And primary endpoints of the FRAME were cumulative incidences of new vertebral fracture at 12 and 24 months, and secondary endpoint, clinical and non-vertebral fracture. After 12 months, new vertebral fracture, clinical fracture, were significantly reduced with the romosozumab in comparison to placebo, but not were reduced non-vertebral fracture in this kind of study, because the study population sample size was not powered to see the effect at non-vertebral fracture level. At 24 months, the rates of vertebral fracture significantly lower in romosozumab group versus placebo after the switch to denosumab with a significant difference. And these are the graphs depicting the effect after 12 months, in which you can see the better performance of romosozumab in reducing the incidence of new vertebral fracture. And in the other graph, we can see the effect of romosozumab transitioned to denosumab better than placebo denosumab in reducing new vertebral fracture. The conclusions of Frame were that in postmenopausal women with osteoporosis, lower risk of vertebral fracture with romosozumab than placebo at 12 months and after the transition to denosumab 24 months. The lower risk of clinical fracture was evident with romosozumab at 1 year of observation. Another important study for romosozumab was a fracture study in postmenopausal women with osteoporosis at high risk, ARCH trial. 4,000 postmenopausal women with osteoporosis and fragility fracture, randomization 1-to-1 ratio to receive monthly subcutaneous romosozumab or weekly oral alendronate, and thereafter open label alendronate in both groups. Primary endpoint, cumulative incidence of new vertebral fracture at 24 months, cumulative incidence of clinical fracture at time of primary analysis, and secondary endpoints, incidences of non-vertebral and hip fracture at the time of primary analysis. During a period of 24 months, new vertebral fracture, clinical fracture, non-vertebral fracture, and hip fracture was decreased better in the romosozumab to alendronate group versus alendronate to alendronate group. So romosozumab to alendronate group is stronger than alendronate to alendronate group. And these are the graphs depicting the effect at 12 months, in which we can see that romosozumab performed better than alendronate in reducing the incidence of new vertebral fracture. And after 24 months, the group romosozumab alendronate is better than alendronate to alendronate in reducing new vertebral fracture again. Conclusions of ARCH trial. In postmenopausal women with osteoporosis at high risk of fracture, there is a significant lower risk of fracture with romosozumab at 12 months, followed by alendronate versus alendronate alone. So it is important to remember that in postmenopausal women with osteoporosis who have completed the course of therapy of romosozumab, a subsequent treatment with anti-resorptive is absolutely recommended to maintain bone mineral density and reduce fracture risk. And let's speak about the so-called sequential therapy for osteoporosis. Basic concept is that we have different kind of treatment, anti-resorptive, bone anabolic agent, now anti-sclerostin antibody, romosozumab, and the opportunity to have different molecules is the basic concept to build a personalized treatment strategies according the individual needs for each patient. Again, the discontinuation of many therapies, denosumab, teriparatide, romosozumab, requires absolutely the switch to another treatment to prevent BMD bone loss and to reduce the subsequent fracture risk. Let's see different clinical cases of sequential therapy that we can meet in our clinical practice. Anti-resorptive after anti-resorptive. If A patient discontinues denosumab, and there is the necessity to limit the so-called rebound effect. Now, bisphosphonate is considered the best choice. Poor compliance with ongoing oral bisphosphonate therapy, injectable denosumab or zoledronate, also to avoid gastrointestinal problem. Occurrence of a new fragility fracture during treatment with oral bisphosphonate, denosumab or zoledronate are more potent and are the most advisable in this case. Antiresorptive agents after agents with anabolic effect if patients with high fracture risk using an anabolic drug stop it. Anabolic effect of drugs is limited, as we know, to 12 in the case of ranozumab or 24 months in the case of teriparatide. And the benefit can be preserved and only with early initiation of antiresorptive agents after their discontinuation. Third case, anabolic agents after antiresorptive agents if patients who experience a new fragility fracture despite bisphosphonate therapy. But we know that the effectiveness of anabolic medication might be impaired when started after a prolonged exposure to a potent antiresorptive drug. If the potent antiresorptive is switched to teriparatide, we know that IP-BMD tends to decline for at least 12 months, especially with denosumab. And some data about combination therapy for osteoporosis. Results from data study, a study that compared teriparatide, denosumab, or the combination of the both agents, the teriparatide plus denosumab, showed clearly that the combination was better in increasing BMD at lumbar spine, distal radius, femoral neck, and total hip. And interestingly, there was a different modulation in terms of osteocalcins, PYNP, CTX, between, on one hand, teriparatide, and on the other hand, denosumab and the combination therapy, showing a different effect, not only at BMD, but also at bone turnover modulation level. And if we look results from data which study in which the drugs used in data study in the year 1 and 2 were switched in the year 3 or 4. For example, teriparatide was switched to denosumab, denosumab to teriparatide, combination to denosumab. We can see different effect. For example, lumbar spine BMD had an increase with all three types of treatment or new treatment. As for hip BMD, there was a difference between combi DMAB and teriparatide DMAB in comparison to DMAB teriparatide, with a less significant effect with DMAB teriparatide. Also for radius, for example. So underlying a different effect of different combination, also in chronological term between different kind of combination, switching from one agent to other. And if we look and change in BMD at 24, 48 months, we can see that respect to the global effect in terms of percent change from 0 to 48 months, we can have a reduction, transient reduction of lumbar spine BMD, hip BMD, an important reduction in distal radius BMD with different combination. And particularly, the combination denosumab teriparatide had the less important effect, with a reduction, important reduction BMD at distal radius. So switching therapy from denosumab to teriparatide resulted in transient bone loss at the hip and spine and progressive bone loss at the radius, while BMD gain, there was a BMD gain with teriparatide switched to denosumab based on different effect on formation and resorption regards to the effect on bone turnover. Data switch study showed, in conclusion, that in postmenopausal women with osteoporosis, the order in which denosumab and teriparatide are used is important for global treatment efficacy. Teriparatide does not adequately prevent bone loss after denosumab, while denosumab stabilizes and increases BMD when used after teriparatide or combination therapy. The largest increases in women treated with 24 months of combined teriparatide denosumab followed by 24 months of DMAB monotherapy. This is very interesting from a clinical point of view. Our conclusion: osteoporosis is usually an underdiagnosed and undertreated disease. Primary endpoint to reduce fracture risk, identification and, if possible, correction of clinical risk factor, and sequential, combined, personalized treatment are our goal in everyday clinical practice. And these are a sort of flow chart in which we can use histoprogestin in premenopause to prevent bone loss and reduce the risk of hip fracture in menopause. And in the early postmenopause, if we have a patient with climacteric symptoms, we can use hormone replacement therapy, estrogen replacement therapy, tissue selective estrogen complex, or Tibolone, with an important protective effect against bone loss and reduction of fracture for hormone replacement therapy and Tibolone, and protection bone mass for TSEC. If we have not symptoms of climateric complaints, we can use SERM with a protection from bone loss and bone fracture risk, and mostly for raloxifene, a reduction for breast cancer risk. And afterwards, we can use bisphosphonate, denosumab, romosozumab in very severe osteoporosis as teriparatide to reduce the vertebral fracture risk in older patients. For all kinds of treatment is recommended an adequate vitamin D and calcium supplementation, physical exercise, adequate diet and lifestyle as recommended. Thank you for your attention.
Thank you, Dr. Lello, for such a wonderful presentation. And now for the Q&A session, we will wait for a few seconds. I remind you that you can submit your text questions at the questions panel in your webinar control panel. All right, we have our first question from Manju Navani. She tells us about a 57-year-old patient who has osteoporosis spine, no hot flashes, nor compression fracture. And her question is, which one is the best RX for her and how to follow up her case?
Yes, I have answered in my last slide, probably. For a relatively young woman, we can use this SERMs because both raloxifene and bacidoxifene are able to protect bone mass and to reduce the transition from normal bone to osteopenic bone and from osteopenic bone to osteoporotic bone. Moreover, if we use raloxifene, we can decrease significantly, as we know very well, the risk of breast cancer, a very important point.
All right. The next question comes from Anna Capozzi. She asks, could we associate HRT with bisphosphonates in selected patients?
Very good question. There are all the data about the use of HRT with conjugated estrogen with alendronate published many years ago by Robert Lindsay, I think, yes, Robert Lindsay, and in which, in these studies, was demonstrated a synergic effect between HRT and bisphosphonate. So, in some clinical cases, selected clinical case, we can use this association, yes.
All right. The next question is from I-Teen. What do you do if patient keeps on fracturing while on TP-TD, on hip fracture?
Fracture during TP-TD?
Mm-hmm. What do you do if patients keep on fracturing while on TP-TD?
Yes, we can switch to denosumab according to the effect of the studies. One possibility is to switch the treatment to denosumab.
Okay, our next question from Manjusha Rathi. She asked, how do you treat an anorexic 34-year young woman with BMD of minus 4.5 who does not want HRT or OC pill? And no history of major fracture, just getting stress fracture.
Yes. This is an intriguing question because on one end, we know that hormone therapy in terms of HRT or estrogen is not so able to restore bone mass in anorexic patient. The only way is to return to a normal body weight and body composition, not only body weight, but mostly body composition with a minimal normal percentage of fat mass, because this is the only way to recover a good BMD for our patient. This is a very difficult condition to treat.
All right. Our next question, another patient case. The patient has 52 years with rheumatoid arthritis, normal DEXA scan of spine and hip, but after HRT for 6 years, at 58 years old, she has osteopenia of spine. Why would this might happen, and what do you recommend?
So we know that HRT can be started before the 60 years of age or within 10 years after last menstrual period. If there are no contraindication, the patients can continue HRT. Probably HRT, transdermal HRT could be better for the minor impact in terms of thromboembolism risk.
Okay. And next question, is there a lowest dose with estradiol patches to treat osteoporosis?
Yes. It should be distinguished between prevention or treatment. We know that we have some data, some interesting and corroborating data about the reduction or risk for fracture with the standard dose, that is 0.625 milligrams of conjugated estrogen or equivalent. And this is the therapeutic dose for treat osteoporosis, for prevent osteoporosis and fracture risk. For a normal prevention in a patient without important loss of BMD, for example, an osteopenia, we can use also low dose 25 micrograms via transdermal route or 0.3 conjugated estrogen or TSEC that contains low dose of conjugated estrogen, 0.45 milligrams of conjugated estrogen. These are all adequate treatment to prevent of the development of osteoporosis.
All right, we have a couple of more questions. In POE, will you recommend only HRT, as COC is not very effective for preventing bone loss?
Yes, in POE is premature ovarian insufficiency, and the recommended therapy is a standard dose of estrogen therapy. So that is 0.5 625 milligrams of conjugated estrogen or 2 milligrams a day of estradiol, not different therapy.
All right, our next question is from Alexandra Gromova. She asks, is there any features to treat osteopenia or osteoporosis patients with contraindications to HRT?
It depends on which kind of contraindication we have for HRT. If we have a contraindication related to thromboembolic risk, we can't use SERMs. So we can use low dosage of bisphosphonate, for example, and probably this is the easier way to prevent osteoporosis in patients with a contraindication for thromboembolic reason. And another kind of reason could be previous estrogen-dependent cancer. We have not the indication for SERMs, the clear indication for SERMs. So low dose of bisphosphonate could be the better choice.
All right. Our next question is, how do you treat a 56 years old patient with recurrent fractures despite normal BMD of 1.0 and no secondary cause for osteoporosis identified? Would you consider giving DMAP or bisphosphonate?
First of all, it's very strange to have this kind of clinical condition without a diagnosis. But if I can choose, I use denosumab.
All right, Dr. Lello, it seems that we do not have any more questions for the moment. So if you want to say any last words to conclude this webinar.
Yes. But I thank to all participants for sharing with me this kind of discussion. And thank you to EMAS, thank you to Lina for your support. And I hope to hear you as soon as possible. Thank you very much.
All right. Many people are congratulating you for your wonderful presentation.
Thank you very much. I'm very happy for this.
Okay. So,
best regards.
All right, so this concludes the webinar. Again, thank you so much, Dr. Lello, for your presentation and all the attendees for being here today. Have a great rest of the day.